Chapter 11: Rapid Response Teams and Code Management. You'll hear a lot of different codes that are going to vary between hospital to hospital. Code Blue, Code 99, Dr. Hart. And these are terms frequently used to refer to medical emergencies, and especially over the intercom. We need people to be coming quickly to know what they're coming to address. But at the same time, we don't want to be blasting exactly what's going on with this patient over the intercom. So they're going to make a code for it. Especially things like cardiac, respiratory arrest, life-threatening cardiac dysrhythmias. In case of cardiopulmonary arrest, this is going to be a rapid response team, and they're going to come quickly to help prevent a code situation. And it's going to involve planning and teamwork to maximize effectiveness. Prevent. They're going to come prepared. These are people that specialize in these high risk emergencies. For the rapid response team concept, this involves the identification of a clinical deterioration that triggers an early notification of specific team of responders. This rapid intervention by the response team that includes both personnel and equipment. It involves an ongoing evaluation through data collection and analysis to help prevent that further better the response in the future. Failure to recognize changes in a patient's condition until major conditions, including death, have occurred is referred as a failure to rescue. These rapid response teams have recently been implemented to address changes in a patient's clinical condition, such as identifying signs that they can intervene before a cardiac or respiratory arrest occurs. The criteria to facilitate early identification of physiological deterioration help nurses determine whether the rapid response teams should be called for a bedside consultation. These teams leads to better outcomes, such as more prompt transfers to critical care, and also works to reduce cardiac arrest and arrest deaths by catching them and intervening early. A code team is an organized approach to managing cardiopulmonary arrest, and they need a system for notifying team members. All team members should be trained in ACLS, and while the team manages the code, other staff members of the unit should attend to the other patients. The team is usually led by an MD, with additional team members consisting of nurses that are usually very skilled in both ICU or ER specialties. Other team members can include a respiratory therapist to help manage the airway or even intubate. Could also include people like a pharmacist, a chaplain, or other specialized personnel. I know many of you already work in the hospital setting as LPNs. And you may have seen codes go on. You may have even been involved in them. And it's going to be a very high stress situation where each person involved identifies their one task to focus on and working together to manage everything that needs to occur simultaneously. Some necessary equipment to be available would include things like a code card, a back or cardiac board, a cardiac monitor, such as a monitor defibrillator, AED, oxygen supplies and delivery devices, airway equipment and suction, medications, IV supplies, NG tubes, to basic things like a BP cuff. Each crash card is labeled as the contents of its drawer, and most cards have equipment stored on top and in several drawers. Equipment such as backboards and portable suction machines may also be attached to the card. Larger equipment is stored on the top of the card or in a large drawer, while smaller items such as medications and IV equipment are in the smaller drawers. Nurses should be very familiar with this card, and frequently checking the card and making sure that everything is current is going to be another critical skill. The nurse can become familiar with the location of items on the card just by being responsible for checking it. Management of the code is more efficient when the nurse knows where items are located in the cart, as well as how to use them. Many institutions require nursing staff to participate in this periodic mock codes to assist in maintaining skills, being assured that you know where everything's located. Because when an emergency is occurring is not the time we need to be looking for things. Should an emergency occur that requires BLS, the code team should be immediately alerted to the patient's code status. And the goal of the BLS is to support or restore effective circulation, oxygenation, and ventilation with a return of spontaneous circulation. Early CPR and early defibrillation with an AED are stressed. In the case of airway and breathing, airway management with manual ventilation, the consideration of intubation, and it's going to be dependent on each patient's unique situation. Remembering back to your BLS courses that I'm sure all of you are currently certified in, there are two methods for opening the airway. There's going to be the head tilt chin lift method or the jaw thrust method that would be recommended in cases where neck injuries are suspected. And here we just have a demonstration of those two methods with the head tilt chin lift method on top and the jaw thrust method on the bottom. Bag valve mask ventilation requires an open airway, and it's also recommended this is connected to an oxygen source set at 15 liters a minute. The face mask should be positioned and sealed over the patient's mouth and nose after opening the airway. And here we just have a demonstration of that bag valve mask, and you can see how she's gripping it so that it forms a nice tight seal. And here we have a demonstration of that bag valve mask being used with an ET tube in an already intubated patient. Once the patient is intubated with an endotracheal tube, placement is verified with an end-tidal CO2 detector device and confirmed by chest X-ray. Here we have an end-tidal CO2 detector, and that'll actually change colors in the presence of carbon dioxide, letting us see that effective ventilation and gas exchange is occurring. In the case of ACLS, circulation is key. We want high-quality chest compressions, monitoring the waveform capnography, identifying any shockable rhythms, which, if you remember back to 2 weeks ago, are going to be VFib or pulseless VTAC. There is a mnemonic to help remember the causes of cardiac arrest called the H's and T's, with H's including things like hypovolemia, hypoxia, hypothermia, while the T's would include things like toxins, tamponade, tension pneumothorax, or trauma. The general flow of events during a code would begin with BLS, as maintaining perfusion is going to be a top priority. From there, it'll then move to more of an ACLS in the complex code, and also an ongoing assessment including pulse oximetry, pulse checks, ABGs, lab work, and don't forget about the environmental control such as crowd control, notification of family and communication, ensuring family presence of a code if they wish to, and if successful, transfer to ICU. ACLS uses an algorithm to guide treatment. And remember to treat the patient, not the monitor. We're going to maintain CPR throughout, and early defibrillation is going to be essential to hopefully reverse that detrimental dysrhythmia. Dysrhythmia is management's an integral part of code management. Nurses, team members, and everyone else involved must be instructed in the application of an AED. Also, things like public access to a defibrillation should be encouraged and as a way to treat this MI or cardiac event as early as possible. As we discussed in our dysrhythmia modules, your two shockable rhythms are going to be VFib, such as there on top, and pulseless VTAC at the bottom. And remember, pulseless is going to be the key part of that. The most common initial rhythms in witnessed sudden cardiac arrest are VFib or pulseless VTAC. And both of these are treated the same with defibrillation between 100, 120 to 200 biphasic or 360 joules with a monophasic defibrillator. We also want to continue CPR after each defibrillation and place a high priority on obtaining IV or, if unable to get an IV, intraosseous cannulation. The CPR, shock, and drug cycles will continue, with epinephrine that can be used every 3 to 5 minutes. Antiarrhythmic medications may also be necessary, such as amiodarone or lidocaine. Here we have two non-shockable rhythms. Remember, we never shock asystole, but these are two other rhythms that you may see in a full cardiac arrest. In the case at the top, that is a PEA or pulseless electrical activity. In that case, the monitor is showing a rhythm, but at the same time, you assess the patient, they are pulseless and apneic. You are getting no actual contractions. What you're seeing on that monitor is the electrical current going through the heart with no response from with the heart cells. At the bottom, obviously, is asystole when we have a complete lack of any electrical activity. Pulseless electrical activity is treated the same as asystole since there's no cardiac output. Asystole is that absence of electrical activity on the ECG. And the key is to assess and treat the underlying cause, as well as maintaining thorough BLS. Remember your H's and T's, as these are some of the very common causes of PEA or asystole as well. Hypoxia, hypovolemia, hypothermia, or on the T side, cardiac tamponade, tension pneumothorax, or even thrombosis. Symptomatic bradycardia is any heart rhythm that is slow enough to cause hemodynamic compromise. And the treatment should focus on maximizing cardiac output through medications such as atropine or even mechanical means such as a transcutaneous pacemaker. We're also going to prioritize airway oxygen, having IV access should this dysrhythmia continue to deteriorate. For mild to moderate symptomatic bradycardia, start with atropine. Go straight to transcutaneous pacing if the patient is unstable or has a high degree AV block. And if transcutaneous pacing is ineffective, consider dopamine or epinephrine infusion while preparing for transvenous pacing. Atropine calms down the vagus nerve, so it'll help bradycardia that's caused above the level of the AV node. If the block is below the AV node, the atropine won't help. On the other end of the spectrum, unstable tachycardia occurs when the heart beats too fast for the patient's clinical condition. The treatment involves rapid recognition and that the signs and symptoms are caused by tachycardia. In this case, synchronized cardioversion or antidysrhythmic therapy may be needed. The patient is in asystole and has lost the IV access. Which of the following would be the appropriate next step? Would that be A, stop chest compressions to place an IV? B, continue high quality chest compressions and administer epinephrine via the ET tube? C, stop chest compressions and obtain an IO? Or D, continue high quality chest compressions and administer atropine via the ET? That answer is going to be B, continue high quality chest compressions and administer epinephrine via the ET tube. The most important part of ACLS and asystole is to maintain high quality chest compressions. Atropine is no longer given for asystole or PE. Remember that early defibrillation saves lives, and the only effective treatment for VFib or pulseless VTAC is defibrillation. In the case of monophasic, where the waveforms deliver current in one direction, or biphasic waveforms deliver the current in a positive direction for a specified duration, and then reverses flow in a negative direction. As a result, fewer joules are needed for defibrillation. Paddles have been used for years and require conductive gel or pads for efficient delivery of current. The pads are more commonly placed and allow safer defibrillation via a hands-off approach, meaning you don't have to be as close to the bed, as anyone touching that patient or the bed does have the risk of electrical shock and injury. So regardless of type, correct paddle and pad placement is going to be key. Here we just have a diagram showing the correct placement of both the paddles as well as the pads. And here we have another diagram showing an alternate method for pad placement. You must implement safety checks to prevent shocking any surrounding personnel. I mean, safety is going to be a top priority in this. And always ensure that the area is clear before initiating a shock, whether it's via paddles or defibrillator pads. You would begin with the paddle or adhesive pad electrodes, and make sure you've maintained good contact with the skin to help protect the patient from burns. You want to charge the defibrillator to the desired setting. Shout clear, I'm going to shock on 3, and then verify that everyone has heard you and is actually clear of that patient. Also keep in mind of disconnecting any oxygen source to remove any risk of fire. Shout 1, 2, 3, shocking, and shock. From there, immediately resume CPR, beginning with chest compressions. When using an automated external defibrillator, AEDs are readily available in many public places, and the training is included in BLS courses so that anyone can use the device. Always ask someone to activate the emergency response system if the device is deployed. Not to be confused with cardioversion, this is the delivery of a shock that is synchronized with the patient's cardiac rhythm. The purpose of cardioversion is to disrupt the ectomic pacemaker that's causing a dysrhythmia, and to allow the SA node to take control of the rhythm. Lower joules are used, and the delivery of the shock occurs on the R wave, To prevent R-on-T, it's appropriate for VTAC, atrial flutter, AFib, or SVT with a pulse, but developing hypotension and decreased level of consciousness. Differentiating it in a basic sense, defibrillation is for no pulse, whereas cardioversion is going to be for a symptomatic dysrhythmia like SVT or other tachycardias. An implantable cardioverter defibrillator is implanted and is able to recognize those ectopic beats and deliver a countershock. It also can work to prevent episodes of sudden death, and the placement of the paddles near the ICD is to be avoided. Many patients now have these ICDs implanted for long-term management of dysrhythmias, and you need to be aware if your patient has that device. Transcutaneous cardiac pacing is used during emergency situations to treat symptomatic bradycardia. Transcutaneous pacing is not recommended for asystole or PEA. In this method of pacing, the heart is stimulated with externally applied adhesive electrode pads that deliver the electrical impulse. While uncomfortable for the patient, therefore sedation and/or analgesia may be needed. In the case of cardiac arrest after cardiac surgery, this is a situation that's not specifically addressed by the ACLS algorithm. And the common causes of arrest are VFib, cardiac tamponade, or major bleeding, and an emergency wrist sternotomy. Let's do an overview of medications. Oxygen is going to be a first-line medication to treat hypoxemia. Oxygen can be delivered via bag valve mask, bag valve device to an ET tube, or other airway adjuncts. And during an arrest, 100% oxygen is administered. Epinephrine is indicated for the restoration of cardiac electrical activity in an arrest. Epinephrine increases automaticity and the force of contraction, an effect that makes the heart more susceptible to successful defibrillation. Epinephrine is used to treat VFib or pulseless VTAC that is unresponsive to initial defibrillation. Atropine is used to increase the heart rate by decreasing the vagal tone. It's indicated for patients with symptomatic bradycardia. Routine use of atropine during PEA or asystole is no longer recommended because it is unlikely to benefit. Amiodarone, on the other hand, is indicated for treatment and prophylaxis of recurring VFib and unstable VTAC refractory to other treatments. In cardiac arrest, it is administered when the VFib or pulseless VTAC are not responsive to CPR, defibrillation, and vasopressors. It is also given in supraventricular tachycardia for rate control, or the conversion of atrial fibrillation or flutter, especially in patients with heart failure. Lidocaine may be considered when VFib or pulseless VTAC is unresponsive to defibrillation. It's also used in the suppression of ventricular ectopy, such as premature ventricular contractions. Usually administered IV or IO, but it can be administered via the ET tube. Adenosine slows conduction through the AV node and interrupts AV node reentrant electrical conduction, which is the cause of most supraventricular dysrhythmias. The drug has a very short half-life and must be given via rapid IV push. If effective, the patient may have a short pause of cardiac rhythm prior to resuming a sinus rhythm. And that slight pause where yours is very tense while you wait on the heart rate to come back. It's the medication equivalent of turning your router off and turning it back on again. Magnesium administered IV may terminate or prevent recurrent episodes of Torsades de Pointes in patients who have a prolonged QT interval. The slower rates are recommended in stable patients, secondary to side effects. Sodium bicarbonate is rarely given in code situations. If needed, it's given to manage severe acidosis, and the dosage is going to be determined by the ABG values. Dopamine is given to manage symptomatic hypotension in the absence of hypovolemia. It is the second-line medication for symptomatic bradycardia after atropine, and its effects are dose-related. The hypovolemia must be treated with fluids if hypotension is related to the volume status. For lifespan considerations, keep in mind that older adults have increased incidence of complications during arrest, such as rib fractures. Higher drug concentrations can be affected with renal and/or hepatic disease, and the differing responses to beta-adrenergics in the elderly adult. There are narrower therapeutic ranges of some medications as well, and left uterine displacement in pregnancy. Here we have an emergency response form code sheet from the Cleveland Clinic, and it's going to be a way to streamline documentation and make sure that nothing is missed in this code, because you're going to find out in codes that a lot of things are happening simultaneously, and we don't want anything to be missed, as thorough documentation is going to be critical, both for the patient as well as to identify ways we could improve for the future. When dealing with the documentation of events, you want to assign someone to a doc events. Their entire job is documentation, including the time started, the actions taken, defibrillation, medications, procedures, intubation and airway management, vital signs, and the team members present. And finally, post resuscitation and debriefing. This can help the team improve communication, process their experiences, and reduce any moral distress and burnout. It also, advanced airway allows for waveform capnography monitoring and maintenance of oxygenation, tissue perfusion, advanced neuro monitoring, targeted temperature management, and anything we need to do to support this patient. As just because we've got perfusion back, this is still a critical patient who's most likely going ICU for sure. One of the most common causes of cardiac arrest is cardiovascular disease and coronary ischemia. A 12-lead ECG should be obtained as soon as possible to determine possible causes. An arterial line or pulmonary artery catheter are also frequently inserted after a code to facilitate hemodynamic assessment and patient treatment. An indwelling urinary catheter may also be inserted to monitor urinary output hourly, as we want to identify any renal damage from this loss of perfusion very quickly. In the case of targeted temperature management, fever post-cardiac arrest is associated with poor neurological recovery. Targeted temperature management would deal with hypothermia, normothermia, and even fever control. The guidelines recommend a temperature between 32 and 36 degrees Celsius for at least 24 hours. The patient's core body temperature should be continuously monitored using an esophageal thermometer, bladder catheter with a temperature probe, or pulmonary artery catheter. Axillary, oral, or tympanic temperature probes do not measure the core body temperature changes and should not be used during therapeutic hypothermia. Bradycardia occurs frequently and is only concerning when symptomatic, and also unresponsive to typical treatment. In the case of hyperglycemia, the patient may require insulin, and you should avoid long-acting subcutaneous insulins. Several nursing interventions can be implemented during therapeutic hypothermia, including monitoring and treating glucose. Electrolyte levels are going to be a high priority. And after 24 hours of cooling, the rewarming process proceeds slowly to prevent sudden vasodilation, hypotension, and shock. Rewarm the patient slowly while also monitoring their vital signs and assessing them carefully. And don't forget that this will be a very difficult time for the family as well. Emotional support for the family during and after a code is important. Many hospitals have implemented procedures to facilitate family presence during codes and invasive procedures. Providing information, active communication, allowing time for visitation after a code, and even offering the support of a chaplain or other nursing staff. Also, keep in mind the other patients involved that are around may have witnessed this code. It may be very shocking for them as well. You want to remove any patients that you can from the situation. Talk with them and assess their feelings. It may be their first time seeing a code, and it can be quite jarring if they don't know what's going on. Quick quiz. The nurse is caring for a patient being treated with targeted temperature management post-CPR. Which order should the nurse question? That be A, draw serum electrolytes stat, B, measure blood glucose every 2 hours, C, continuously monitor the EEG and ECG, or D, record tympanic temperatures every hour. And that answer is going to be D, record a tympanic temperature every hour. Remember, tympanic methods are not accurate, and we want to be assessing that patient's core temperature. Another quiz. A 56-year-old female patient reports feeling fatigued with sudden nausea and lightheadedness. Which action should the nurse take immediately? A, call the charge nurse. B, get the patient an antiemetic. C, call the attending physician. Or D, notify the rapid response team. And that answer is going to be D, notify the rapid response team. This female patient's having symptoms that may be an AMI. It's an indication to call the rapid response team to prevent a cardiac arrest through early intervention. The other choices would delay action, and this patient needs to avoid a failure to rescue situation. For our key points, a rapid response team is a multi-professional response to a deteriorating or worsening patient clinical status. You want rapid initiation of BLS and ACLS protocols, and competencies required associated with everything from the code card and documentation to the defibrillator and medication management. Effective support is going to be necessary for the return of spontaneous circulation. And electrical therapy and medication administration may be also required to achieve ROSC and treat conditions that could initiate a rapid response team. And finally, post-cardiac arrest management is going to be key. But anyway, that's all we got for this slides. I'll see you in the next chapter.